Hello everyone, welcome to my PowerPoint presentation online. I'm going to speak to you today about implant provisionalization, the nuts and bolts of how to take a conventional denture at time of implant surgery. We know it as the all-on X or the all-on 4, and make it into a good provisional. And what are some of the things that the general practitioner and or specialist needs to know in regards to this therapy? A little bit about me. I'm a native of the Pacific Northwest. I graduated Marquette School of Dentistry in 2005. I started up a restorative practice in Post Falls, and since then I've taken over for a prosthodontist in my hometown of Spokane, as a prosthetic partnership practice in that city. Um, I'm not really a big fish, but I do lecture locally at study groups. I have quite a few affiliations, and I'm kind of a dental nerd to say the least. So let's give the overview of what we're going to talk about. We're going to talk a little bit about the diagnosis and treatment planning. So the team, which is the oral surgeon and the restorative dentist, financial consult and agreement to our patients, so you can understand how I approach these things so you don't waste a lot of chair time. We coordinate the surgery and the pickup at the same day in the oral surgeon's office. And we want to make sure that you also have the proper materials to do this kind of setup. And then always make sure you have plenty of time for a 24-hour bite follow-up, because that's also very important. So what is their purpose for provisionalizing someone after implant surgery? It is to basically give them immediate, semi-immediate function after surgery. It's also used to stabilize the newly placed implants via cross-arch stability. And cross-arch stability basically means that any of you who've ever built a fence understands that when you pour a fresh batch of concrete and put a fence post in, it is better stabilized when you have cross support from 2x4s. So that's what our prosthetic essentially does. It allows the implants to be stabilized in one rigid substructure, which is our acrylic top or our denture. And then one of the most important things I think that gets overlooked is it helps us evaluate future aesthetics and function in the towards our final prosthetic. So if you understand the pitfalls with your current reconstruction, you may want to lengthen the teeth, you may want to widen the buccal corridor and the upper plate to give more of an ascending smile line, maybe open up the vertical dimension more, lessen it, etc. So I think this is probably the most beneficial thing as general dentists that we can do moving forward into our finals. So in this, it allows us to evaluate proper soft tissue support, meaning our lips. Allows us to evaluate proper phonetics, and that's a huge thing. And I'm a believer of, if you put the teeth in the right position and you design a denture with um, with the idea of phonetics in mind, the aesthetics are easy, okay? Because our lips are going to be in unison with the neutral space where you place the teeth. And so smiling should also be natural. So I'm a big believer in that. And of course, we want to evaluate the proper aesthetics and Frankfurt. And, this is just a brief example of immediate provisionalization. We used his old denture. We knew that we needed to open him up a little bit, but if we look to the picture on the right, we do have his final, and that is a regular upper denture opposing his lower all-on 6. So I believe it turned out really, really nice. So the things you must know is you have to understand the capabilities of your implant system and the components. Understand what the names mean and how to use them. You also have to realize that the patient will be very exhausted and either fully sedated or partially sedated after surgery, and it becomes very difficult to do these things chairside in these patients. The other thing you must be aware of as the restorative dentist is you must take the steps not to leave any restorative materials behind during your provisionalization. Now, that doesn't mean on the counter at your oral surgeon's office, but it does mean underneath the wound, okay? Things that get caught in the stitches, underneath a flap, underneath the tongue, those are not good things to have on a healing implant. So the biggest caveat that I can give you out of this whole lecture is you have to take the time to make sure each coping and screw is passive, okay? So if you finish off your provisionalization, or even if your lab does it for you, and you're finding yourself having to do the infamous screw dance, where you put one screw in here, and then, try another one in, it won't go, so you loosen up the first one, then the second one goes in, kinda, that means things are not accurate and wrong. You have to redo your pickup. And I'm going to show you the steps when you're first beginning to do this, how to do it where you don't have issues. Occlusion follows secondly behind, and in the beginning I alluded to a 24-hour follow-up visit, and the reason why we want to do that is because people's bite change. In 24 hours, they're no longer numb. Their musculature is kind of a little bit rested from surgery. So do yourself a favor, bring them back, make sure there's no working interferences. There is a great tripod occlusion. I like doing posterior. I like doing a little bit on the anterior, so it stabilizes the upper plate as well. And then, of course, when you design your hybrid, prosthetic, your provisional, you want to make sure the antaglio side is clean and be able to be clean. So when you're said and done with everything, this is how it should kind of look. Um, and we will talk about, the ideas of no cantilevers, having the underside convex and scallop to where, patients as they heal can clean it easily. So the denture fabrication, in my eyes, is a very important step. And most people that we see for cases like this, not all of them, are getting a denture or come in with an existing denture opposing a lower partial. And something is pushing them into a lower hybrid, and it's usually those few teeth that are holding in a lower partial are no longer good to hold the partial in. So we take them into more of a generalized hybrid therapy. So the biggest thing is you want to think of the end point for your aesthetics and functions. How is the Frankfurt plane? And you want to make these changes. They're easy to do now because we can grind on these temporaries, okay? And, of course, everything needs to be accurate as we move on with the fabrication of it. So once we get through the initial setup for the final, or not, excuse me, not the final, but for the going to surgery step, I like to schedule surgery and prosthetics the same day, and I work with a couple amazing oral surgeons that do allow me to enter their office and do chairside provisionalizations. Now, some of you might hire a lab to do it, and that's okay, but I still think if you are diagnosing and you're going to take the risk for the final result, you should understand the process, and it makes you better appreciate the pitfalls when, if something does go on and the lab tries to blame you for it somehow. I think it's good that you have that. So I like to have it in the oral surgeon's office because it takes me away from my element. I'm not dealing with hygiene exams. I'm not dealing with patient calls. I can solely, give my attention to that patient and that procedure. And then you want to plan for, usually for your first couple cases, a whole afternoon, possibly evening. because these things. So let's go back to the idea of patients that come in with an upper denture. If you do have a patient who is non-dentate anymore, you want to focus all your efforts on the upper denture, make sure it's level and flat, because this will be the foundation for how your lower bite will be. And our palate does provide one and only predictable reference point. And our palate will not change throughout life, so we will utilize that as our vertical stop in this process. So it's kind of a good thing to have. So in this case, she had a little bit of a cant in her Frankfurt plane. So we basically ground it and did a soft reline prior to get things settled and straight. So um, one thing that we like to use at time of surgery, and of course I'm jumping ahead, I'm not giving you the surgical steps because this main lecture is focusing on the provisionalization aspects of it. But surgery is done. This is at time of surgery, and we do place a rubber dam in to isolate, again, the materials from the surgical site. This to me is a very important step because we're going to be using blue mousses, we're going to be using polyvinyls, and bite registration material that we don't want in the wound. Okay, so once we get things isolated, we're going to do our abutment level impression. In these cases, I do have my oral surgeon put the multi-units on for me. And the reason why I do that is because, well, the patient's flipped open. I mean, you don't get better access at the point of having the implants fully exposed with no tissue in the way. And as long as you're there and you're guiding the oral surgeon, if they don't feel comfortable with what you need, then, it's a win-win for everyone. And so with that being said, the open tray impression copings are placed on top of the multi-unit abutments in an open stock tray. Okay, we're not worrying about accuracy in terms of the custom trays or anything. There's no need for that because we're going to work that out in the end, and we're not really capturing the soft tissue because the soft tissue is right now mangled and sutured and it will change. So our main thing here is capturing these implant placements at the moment. So right from taking the impression, I go right to my lab and I just do a quick pour. I just pour up. I get some multi-unit analogs, put it in the stone, and this will kind of give me a verification cast, and it allows me to pick up some, finish the denture, and now I will have this model until we work on the final. And what's cool about this model is if any of you out there in this audience have worked on patients through that 3 to 6 month period of wearing a provisional, sometimes they break these things. And it's sure nice to be able to have a model that is fairly accurate to where you can repair that denture. And then let's say they go through that 3 to 6 months and everything's fine. Well, guess what? Now you have this model to make your verification jig working into your final denture or your final hybrid prosthetic. So once I have my working model, it's time to work on the lower denture and getting it to seat inside the mouth post-surgery over the multi-units. And so it's going to require some removing of flanges so it would fit over the multi-units. And for illustration purposes, I end up using some yellow paste to show where the multi-units are in reference to the underside of the denture. And you can see by the red arrow the length of the cantilever that I'm going to leave in reference to those multi-units because I don't want anything that's going to be hanging off the back of those. And the second thing it does, it's unwanted denture flange and material that will prohibit you from seating your denture in properly. And if you do seat it in with that on, in my experience, it's been too high, meaning the back of the denture is going to be sitting high, and you're going to end up with a molar-only occlusion. So Most dentists who start out doing this, and it's happened to me, I used to do it where I kept everything intact, and I end up having to grind the back occlusion flat so the patient could properly close and they wouldn't have an anterior open bite. So that's just something to keep in mind when you are doing the step. So now once I have my denture passive, I do two other steps. The picture to the left, I basically took a bite registration with both dentures outside the mouth because I know how I designed the bite. And that's ideally where I want my patient after the pickup. And the picture on the right is showing you the index that I've created by having the patient bite into that underside of the denture with blue mousse. And then how I verify this is I remove the the inner occlusal blue mousse that created the bite, and I just leave the lower denture in, opposing the upper denture, and I have them just move their jaw around and make sure that they land how they should. So this is a very important step because this is going to be a start of where your denture is going to sit, right to left, front to back, up to down. And if you are getting a good, repetitive, repredictable bite by your patient, the chances of having it almost be perfect is 98% there. Okay, so what my next step is going to be, as the blue mousse is still into the underside, and I know that's where I want the lower jaw to be, I'm going to go ahead and start drilling through the blue mousse to create the beginning of the pilot holes where my temporary copings will fit through. So this is what the denture now looks like after I start the pilot holes with the blue mousse. And what I want everyone to look at is, you can see how it should look after you remove after you drill through your blue mousse and you start engaging the acrylic. And then I do that with all my holes. And then what I do is I remove the blue mousse, and allows me to follow that trajectory of the first hole here, and I can bore through all the way. And I'm showing you the progressiveness on kind of how it goes. So through the blue mousse is here to the this area, and then it becomes this, and then it becomes this. And then when you're done, you should have 6 contiguous holes of kind of where it should come out at, okay? And it just saves you a lot of time, because otherwise you can't see through the acrylic and you're really guessing where your hole's going to be. And this is important because even though we do use a processed acrylic underneath, it doesn't get any stronger than the denture base, and this is what's holding the teeth into the prosthetic. So the more of the original base you can preserve, the better. And this is just one way to do it, is by using the same blue mousse index that you had in the prior step. So now once you have your lower denture calibrated and you have all of your pilot holes drilled, you're going to start with your very first pickup. And in the picture, you can see the multi-unit coping that sits on top of the multi-unit abutment. And this is representing a plastic cylinder. I nowadays use titanium for multiple reasons. And the first reason is, with plastic, you don't get a definitive stop when you screw it in. You can always go a little more. So you don't know if it's truly seating all the way. And as you can see in some of the pictures, there's stitches in the way on top of the abutments. There's tissue. And by having a cylinder such as titanium that you can screw down and the screw stops, you know when it stops, you know you're down. Okay, so um, the other thing with the plastic cylinder, it doesn't show up on the x-ray very well. So, and sometimes not at all. So by using metal, it will help you verify that your pickup on that step is accurate. And so at this point, we screw it in, and then we're going to put the upper denture on top of this multi-unit. Okay, so here I am I'm showing the denture in place. Rubber dam still underneath. Okay, I put it back on, and you can briefly see the rubber dam right here. Okay, so we put it back in, and then I'm squirting in some gum shade resin, and I'm just doing a real basic adhesion of the very first multi-unit to the denture base, and this allows me to that I got one of them picked up, and here we go. We can see it picked up onto the denture, and that's that unit right there. Okay, so once I get the very first unit picked up in the mouth, I will pick up another one, and then I will pick up a third one. I like getting some kind of a tripod, and the reason why I like that, it gives me a way to verify my steps that I did in my blue moose. So is my yaw correct? So that's my right to left in the posterior. Or is the patient biting correctly? Is my vertical heights right? And then once I get my trifecta and I verify there's no preloads, it screws in straight, I'm going to go ahead and take my denture to the model. Now the model from probably 8 slides ago, I'm screwing it on and I'm making sure it's just as passive as it was in the mouth. Now, one thing that I'm going to show you coming up is that before I pick up my other 3, I'm going to take an x-ray and I'm going to make sure that things are sitting properly. Now, I talked about these are plastic, they won't show, but I am going to show you a future slide of the copings that are titanium, and you'll be able to see the step that should happen before you pick up the other ones. So these steps that are tedious, the picking them up one by one, checking it in and out of the mouth, every time you pick one up, to make sure the screws are going in smoothly and everything's sitting flat, and doing your x-rays is because you don't want any preload in your screw or into your denture. And so we call this in our field, obviously, preloads. And a preload, if you have it, is meaning that something's not accurate in your pickup. So this is usually an open cylinder, an open coping against your multi-unit abutment. And this preload, if you really try to wrench it down, it makes your prosthetic like a loaded spring. So you're putting unwanted constant force on a healing implant that's new. And then it's also putting stresses on the prosthetic, and you can break a screw. You can lose the preload in the screw, so the screw comes loose after you seat it in a week later, and then the patient comes back with their prosthetic in 3 or 4 pieces. So this is a very, very important, as you go through each cylinder, you make sure that it is passive as it was before you put anything on it. So from the Journal of Prosthetic Dentistry, 2008, we know that a non-passive provisional produces more peak stress on each component, and which can lead to breakage of the prosthetic or implant failure. So again, this isn't me making this up. The peak stress can cause progressive reduction in the preload within the prosthetic screw. So if you've ever had a single unit crown implant come loose before, there are multiple reasons why it can, but it also could be that it's not seating all the way down, okay? And so if the screw loosens and it breaks, that is considered the second leading complication that we have with these all on 4 cases or all on X. And the first leading cause of failure is our acrylics breaking. So just follow these steps and you shouldn't have any problems, especially if you're new at this. If you've done a lot of them and you got your technique down, you understand what I'm talking about, and you're doing things right if you don't have these complications. So this is a slide showing you what happens when we don't follow those rules and we don't have a passive fit. And this is one of the reasons why now I use titanium. This is one of my cases that did break, and I believe it was about a month after I put it in. And I tell you what, the only saving grace is that I had her model. And so what I did is I basically picked it up on the model, I tried it in the mouth, and I verified it to make sure. So it worked out wonderful. But these are things that really can disrupt your day, especially when you're not planning on these patients coming in, because it's a lot of chair time. You got to unscrew the prosthetic, and if you don't have a way to repair it, or the components like an extra coping, or what if they broke a screw and swallowed it, you're going to have to, it really ruins your day, in other words. So by following the steps prior, you can avoid what you see on the screen. And these are some of my failures that I used to do quite a bit in the very beginning, but it made me a better practitioner today, and I understand these cases so much more by my failures. So this is a Panorex of another one of my failures early on in my career. So the progressive from the previous picture where you saw the posterior component break with a plastic cylinder, I learned from that. So then I moved to titanium cylinders. And then I took an x-ray, and I see that my cylinders aren't sitting down all the way. Now, the good news is if you would see a clinical picture of this, is I have the patient's denture, and I have the copings luted to the denture, but I don't have the denture processed yet. So because these are not fitting, I had to go back and I had to break the luting connection between the coping and the denture base and re-pick them up one by one. Okay, and if it's not very clear, you can see gapping here, and there's two others here, but it should look like, I'm going to use a different color. When you're done, it should look like this one here on the patient's right. It should look like it's solid. Okay, now when we zoom in, we can see that the coping isn't passive. Um, and so if you use plastic copings, you won't see this. These are titanium copings we're seeing in this x-ray. And and the main reason why I have moved to it is for that reason. I can see where I messed up. And if things aren't picked up right, or the denture moves and the next one's not seated right, this is what happens. Okay. So you need to take those copings out, and you need. So I re-picked up those copings that were not passive, and we're going to go ahead and try it back into the mouth and do another x-ray to make sure that what I'm feeling in the mouth is correct. Now with our next x-ray, we can see after the re-pickup of the cylinders, they are now sitting as they should. And this assures that there's no preload on any implant. There's no preload on my prosthetic. The only preload there is the tightening within the screw after I seat it. So this is exactly what you should see when you do your pickup. So now we verified all of our cylinders are passive. We took x-rays, we felt it in the mouth, we verified the bite. Everything looks good. Now is the time that we can move it to processing. And as you can see on the picture on to the left-hand side of your screen, we do have cold cured acrylic poured into the intaglio side of the denture, filling in those voids that we did have from the pickups. And I am using now a pressure pot, which is something in my early career I didn't do, but to make sure that you don't have those patients that are sensitive to acrylics and the monomers, you have to process it with some sort of a pressure pot, whether it's this portable one that I use or one from Walmart that is a food pressure cooker. But I recommend doing it, otherwise you're going to have some real bad tissue with these people. And this is another important step of making the acrylic as strong as we can, is to pressurize this. So once we got everything processed in, we're going to seal all the voids on the underside. We're going to make sure the intaglio side is convex, and we're going to scallop near the copings for hygiene. And then we're going to remove the excess length of the copings on the occlusal side of it. And then we're finally going to polish it. So once you have everything processed and finished, this is kind of what it should look like. It should be smooth, free of voids. It should be properly shaped. And then on top as well, it should also be smooth because the patients will find any irregularity after this therapy, any kind of hole, perforation, and they will drive you nuts with it. So spend the extra time and do it right. Now, one thing I do want to note to you guys, this is a picture of one of my earlier cases where I did use the plastic copings. And one other thing I failed to mention prior is another reason why I don't like using these copings anymore is when you have to start grinding around on the acrylic to clean it up, you can actually nick these plastic cylinders, and because it's plastic, it will break. You can ruin them. So titanium gives you a little bit more leverage. Um, and plus with the titanium, if you have extra analogs, you can screw them in so you can make sure you don't damage the very lip of them, and that helps you not get any materials into the underside of these copings. So, but also as well, we can see, I just made on the picture on the left, I just made enough clearance for enough denture base around that hole. And this is more of what I should have onto the right side. It gives a little more strength in the denture base, but again, we want to minimize the cantilever because that becomes very important. Okay, and then of course we want to make sure the bite's even. So now we go directly into the mouth. We can still see some bruising from surgery. And then we want to, if you can't torque them to 15 Newton centimeters, sometimes the oral surgeon says just lightly hand tighten them. Please listen to your oral surgeon because maybe there's one implant that doesn't have as good primary stability as others. So make sure that you listen to your oral surgeon and understand which units or unit you should not be putting torque on yet. And then I usually close the screw access holes with VPS such as honeycomb, and I don't want to use composite in the provisional because this thing will be coming on and off more times than not when we get closer to the stages of working towards the final. So make sure you have an easy access way, save yourself chair time to go in and out. So, the process of getting to your final provisional, it's a daunting task, but it's also really rewarding. And especially if you can see the picture to the left, where the patient came from, lower normal teeth, opposing her old upper denture. You can tell aesthetically it just aged her and her function wasn't right. And then immediately after surgery, that's the picture to the right, we can do something like that and just look how that changed her whole look. I mean, it basically made her look so much younger. You can actually still see she's still numb on the bottom, but very, very good results if we follow these steps. So after surgery, do your pictures, examine them, and then you should already have them scheduled to see you the day after. And the reason why you're going to do this is you're going to make sure that the neuromusculature hasn't changed. I mean, they were sedated, they were open for a long time, and in the case that we showed you, this patient had her teeth, and so she had some sort of proprioception on where she should be biting. So our pickup was based upon her centric relation of her jaw joint and the reference point that was created that her upper denture had on her palate. And so that's all we had to go from. And so it's important that we do this 24-hour bite check to make sure nothing is truly messed up. Um, and at this time, you're going to just verify the patients are comfortable, and you're going to stress a soft diet, nothing more than a noodle type toughness until the oral surgeon advises differently. Because I don't want anything that we say or do interfere with what the oral surgeon has done. Right now, they're still kind of the primary, for this case. And then, of course, minimal hygiene underneath the denture. So no water picks, no flossing. And again, I throw this in the oral surgeon's court because they will clear you to remove it. They will clear you to say when they're healed enough to clean underneath it. So don't give them the advice. Draw it back to your oral surgeon. And if they don't know, it's obviously common sense. You don't want to put high pressure or scrubbing actions on a healing wound because it won't heal, and you create and extend out the inflammation to where you'll lose an implant. Okay. So a 24-hour bite check, there we go, full smile, not bad, but I can tell you in her final, we did change how much she shows, so we're going to ramp up her occlusal plane a little bit. All right, so once you got the patient dialed in with the bite, it's just now a waiting game. And for the mandible, it's usually 3 to 4 months. Maxilla is usually 6 months because of the discrepancy, with the bone and primary stabilization. And the oral surgeon will give you the clearance for this. And so now, once you get the clearance, you can go ahead and start the steps for your final uh, prosthetic fabrication. And then at this time, I do like to talk to my patients about cleaning because once they get cleared, they feel like, oh, I'm healed, I can do whatever I want. And to an extent, their diet still needs to be soft because it's fragile acrylic. But also the hygiene part becomes important, and you let them know. And again, this is what I've done in my office. I let them know once they get their final, we are going to go ahead and we're going to give them a 3-month cleaning for the first year. So I'm going to see them throughout the first year for 4 times every 3 months. And the reason why I do that is because they have no clue how to clean these things. Okay, so they think they're cleaning it, but they really aren't. And it allows you to follow how their tissue looks. It allows you to see the underside of the denture, how much debris, how much tartar, and you can direct them to do the proper types of home care and give them the right tools. So with each progressive cleaning, they should be good. So at that year mark, if they look fine and they're doing well, then I will push them to a 6-month recare. I usually don't go further than that because acrylics are stinky and they do pick up nastiness a lot easier than our own teeth. So I don't go any further out than 2 times a year cleaning after they get stabilized in their final. So now I wanted to show you guys the end result to this patient. So we have her before to the left, old denture, lower natural teeth. And now we can see her final prosthetic, her new final denture on top with her lower all on 6. And patient's very happy. She's functioning and speaking fine. And what I like about these cases, these are the closest that we can get in our dental profession to saving someone's life and giving them back life they didn't have. And so here I wanted to show you the transition from her provisional to her final. And on the left is obviously her provisional stage, which you guys have seen in previous slides. And then, of course, her final. And I think it turned out really nice. She's very happy with it, and it's very natural looking. So here is a Panorex at the time of a 3-year follow-up that we did with her, and we can see her final framework bolted into place. And the biggest thing that I want you guys to look at is where the framework touches the multi-units. Every single one is almost undetectable as it goes into the multi-unit copings. And that's what's key, and that's what makes these type of therapies a long-term option. And when these things are done right, they can last a lifetime, literally. So I know this says a 3-year follow-up, but I did this lecture a few years ago, and I'm just kind of revisited this lecture, and this is about now 6 years that she had it, and she's doing well still, and very, very happy that we did this therapy. So here's a picture of that 3-year follow-up. We can see that she's wearing her denture very well. I'm not seeing a lot of defects. Her bite is still well, and she's loving it. She's eating things. For the most part, most average people will do. And one question that comes up typically with these is, well, we do say they share a 98% success rate, but you have to tell your patients that all the metal components, the implants, the multi-unit abutments, and the framework are pretty much the forever pieces of these cases. The acrylic and the plastics will wear down, and so it is important that you do hang on to their temporaries, because there will come a point in time to where you will have to repair and or rebase the lower or the upper, depending on which arch you do, and you want a way to put their spare tire on while their main tire is out to the shop getting fixed. So that is just another little tidbit I recommend, is you make sure you hang on to their provisionals once they're into their final. So I wanted to thank everyone for spending their time and listening to this presentation, and hopefully it will help you out in your practice. And um, this is a good lecture for those of you who have never done these cases before but want to get into the provisionalization side of a hybrid pickup. And I'm sure there's some in the audiences who have their own way of doing it, and that's great. But if you got any questions for me at all or any concerns, you have my contact information in both of my offices, and I would love for you to subscribe to my channel, because there are more vlogs that will come, and I do have a lot more lectures that I would like to share with you guys as it relates to dentistry as a whole. So thank you very much, and have a wonderful day.